sometimes people can have very complicated vasculature, especially the venous system. Dr. Zamboni, if I recall correctly, he found a lot of problems in the azygos also. He used ultrasound in order to study the dynamics, so he would look at the flow with the ultrasound, he would look at stenosis with ultrasound, and he could do that real time, which is a very big advantage. So he could watch the flow throughout every heartbeat and pick up that information. And so even though there may be some difficulties with having to put pressure on the neck and questions that arise about compression of the jugular, those people who are skilled with that, they know how to deal with this issue. But ultrasound also has trouble penetrating deeply, and it does a good job for the surface. There are special ultrasound units called transcranial ultrasound that can actually probe vessels in the brain, as work he did in the straight sinus, for example. From my perspective, we're interested in more of the three-dimensional nature of MR angiography. That gives us the ability to look at all the arteries and the veins in your head, your neck, and the aortic arch, and also in the spine. And with that three-dimensional information, we feel that that could be a very good treatment planning procedure for the interventionalist. And also, again, remember, it stands for, it's kind of the control for the patient before they've been treated. We can then look at the blood flow at a variety of locations in the neck, and right now we're looking at 3 different locations in the neck. One in the lower level by the confluence of the jugular with the subclavian, and then we go all the way up to C1, C2. We can measure the blood flow in every major vessel in the neck, and so this gives us cardiovascular input-output associated with this. So that's a big advantage if the patient is going to then have a scan sometimes later in the future where, from the neurologist's perspective, he or she will get all of the conventional scanning, so the neurologist will have the information they need pre and post, which will also be important from a research perspective, but we'll also be able to quantify that blood flow before and after treatment. So we can, rather than the patient saying, well, I feel better, we can give this a real objective determination that the blood flow has changed from 12 milliliters per second to maybe 13 or 14 milliliters per second, or whatever it does change to. And so all this information becomes part and parcel of the care of the patient. And so I just wondered if, Joseph, you might speak a little bit from your perspective to the needs of imaging, and of course angiography is another form of imaging. How do these complement each other?
You know, in my mind, there's sort of 3 sets of imaging, as you discussed, Mark. There's Doppler, there's MRI, and there's the angiography. And of course, the angiography has classically been considered the gold standard, which is a term we use in medicine to denote the thing that gives us the best answers the most often. And I would still say that, but I think that these other imaging modalities are very important in the overall treatment and care of patients with CCSVI. And I think this idea of marrying the 2 really improves the overall treatment. Doppler, I think, is a useful tool. It's a good screening tool. It allows me to get a broad idea whether or not you fall into a normal or abnormal category. Having said that, I prefer the MRI. And I think it's important for patients' sake to make a distinction between the normal MRIs that MS patients normally get and the MRI that Dr. Haacke performs. Right. The normal MRI that most patients get for MS is looking at the plaques in the brain. Right. Pretty simply, right? Mm-hmm. When I talk to patients about the MRI that Dr. Haacke performs, it's much more detailed MRI, okay? And it's very useful to us as a practice. First of all, it's giving us flow data of these veins. This flow data is going to point us in the direction of narrowings or stenoses that may not have been completely obvious on the venogram, okay? And really what that lends itself to is a more thorough and complete treatment. It's more information, and more information in this case is a good thing. Right. It is also useful in that it provides us with a very good MRV, a map, so to speak, a road map of these veins. And this road map is just as if you were going to drive from one side of Detroit to the other. You'd rather have a road map. You'd get there easier, more safely, more effectively. Occasionally, it'll change how we treat the patient. A good example of that is the azygos vein. The azygous vein can have a variety of different anatomic configurations, and it may change how we approach our treatment to the azygous vein. A typical approach for treating CCSVI patients is through the groin. The azygous vein, by way of example, may have an anatomic configuration that may encourage us to go through the arm instead. It may make the approach to that vessel easier. And without the MRI, we may or may not have known to do that. And I also think that the iron quantification that the MRI provides is, it's going to be a good surrogate marker in some manner in the future for, who knows, treatment success, medication, staging of the disease. We talked about doing the research while we're doing the treatment. If we're going to be doing this and undertaking this task with any degree of seriousness, we have to be, whenever we have a chance to apply science and extract information from what we're doing, I think we're obligated to do that. And the ultrasound, while it does provide some information, I think the MRI provides much more information that we're going to be able to take in the future and create those lines of causality and those lines of causation between treatment and outcomes. I think the other advantage of the MRI, quite frankly, is it significantly decreases the degree of inter-operator variability. Ultrasound is like knowledge. A little knowledge can be a dangerous thing, right? I can put an ultrasound in your hand, and with a well-trained technician, we can get a good study. With a poorly trained technician, that study may not be quite as useful. And those CCSVI criteria that we all like to talk about may come into question. People who will have 1 or 2 CCSVI criteria by ultrasound, then when we do the MRI, there's gross abnormalities. I guess what I would say in summary is that I think the imaging, of course, is very, very useful, not just from a treatment perspective, but also from the other half of what we're trying to do is establish the science and the causality and the relationship behind what we're seeing and what we think is abnormal and the treatment we're doing to try and improve the lives of the MS patients.
It would be nice if we can integrate a lot of these imaging tools together to get a more complete picture, and perhaps later you can speak to the role of IVUS or intravascular ultrasound. But to really answer one of the critical questions is why are some people benefiting from this treatment and fairly well, and others aren't benefiting as well. In order to really study that, I think what we're finding is that there are tremendous variants. Although the valves may be playing one of the most important roles, there are such anatomical variations that we can see the truncular venous malformations, which are basically, you get a jugular stump that often only has a tiny little string feeding up to the rest of the jugular. Well, luckily, if that's the case, you can still get in with a catheter and balloon that. We see cases where some people have beautiful engorgement of the vertebral plexus, which is then served as collaterals for allowing the blood to get out of the brain correctly. But there are some people who don't seem to be able to get that development. And so in terms of looking at all the variables, from our perspective at the moment, there appear to be dozens of variables associated with this. And for us to draw conclusions as to why one person who has perhaps almost the same truncular venous malformation benefits far better from the operation than someone else, we're going to have to study the entire vasculature of the system in order to do it. We're going to have to understand these dozens of variables, and that's going to take time and probably a study of hundreds, if not thousands, of MS patients before we can get to that point. And I think that's a critical role at the moment that the imaging is going to play, because you may have treated them and they may recover, they may not recover. So our hope is that imaging will be a means by which we can really help understand, maybe even eventually predict, who will recover from this sort of thing.